Yes, sir.
Yeah. Good evening, doctor. Warm regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. K. Mayor Lakshmi ma'am. She is a HOD professor, Department of Medical Oncology, Nizam
Your
Center,
voice
Medical
is not
Sciences, Kanpur.
audible. I don't know why. I'm not able to hear anybody's voice.
Ma'am, we can hear you.
Madam, you're audible.
Madam is
I don't
audible.
know. Somehow you're. I'll try to get the earphones. Sandeep, shall we start the meeting?
Yes, ma'am.
Just a moment.
Hello, ma'am. Can you hear us now?
Pardon? Is my voice audible?
Yes, ma'am. SS.
Okay.
Yes, ma'am, you're audible.
So, what did Sandeep say? Shall we start?
Yes, ma'am.
So, a very good evening, everybody. Today's evening, we'll be going to discuss prostate carcinoma. We have two eminent speakers with us today, Dr. Shaini Reddy and Dr. Rajni Priya. Both of us will be delivering talks on the latest advances in the treatment of prostate cancer. The first talk is talked by Dr. Shaini. Over to Shaini. After that, we'll have a discussion towards the end. I'll presenting a case and a few questions we'll be discussing. Shaini, can you start?
Yeah, sure, madam. Thank you, ma'am. Thank you for the introduction. At the outset, I would like to thank Bayer for the opportunity. I hope I'm audible, right?
Yes, ma'am. You're audible.
Madam, you are
Yeah, thank you. Yeah, Sandeep, can you present the slides?
Yes, ma'am. Share the slide. Sorry for the delay.
No problem. Yeah. Can you go to the first slide? Sandeep, can you go to the first slide? Okay.
Ma'am,
Can you
please
put the
proceed.
introduction slide? Yeah, please put the introduction slide. The first slide. Yeah, thank you. So shall we start? Good evening, everyone. So today I will be discussing the evolving treatment landscape of metastatic hormone-sensitive prostate cancer, specifically how our treatment goals have shifted from merely palliation with androgen deprivation therapy to aggressive early disease control with treatment intensification. Next slide, please. So these are my disclosures. Next slide, please. So this slide beautifully summarizes the natural history of prostate cancer. Most of our patients, they move from localized disease to biochemical recurrence to metastatic hormone sensitive disease, and ultimately they will move to metastatic castration resistant prostate cancer. So historically, only androgen deprivation therapy was our backbone across all these stages. But the critical point here is that almost all patients who die from prostate cancer, they eventually they develop castrate-resistant prostate cancer. And once the patients enter this metastatic castrate-resistant prostate cancer phase, the survival gains are very modest despite giving multiple therapies. Even successful metastatic castration-resistant prostate cancer therapies, most of them, they improve the overall survival only by 2.5 to 5 months, something like that. So here comes an important question, whether we can intervene earlier before the resistant clones dominate. Next slide, please. Next slide. So as I already discussed, the tumor cells at the metastatic hormone sensitive prostate cancer stage, they're relatively hormone sensitive. That means we can achieve deeper PSA responses, we can achieve longer disease control, delayed emergence of resistant clones, and ultimately improved survival if we can intervene at this stage. So the aim today is not just merely to suppress the testosterone. We aim at maximum upfront disease control, delaying the progression to castration-resistant prostate cancer, preserving the quality of life for the patient, and thereby prolonging the overall survival. So the concept of hitting hard and hitting early has become central to the management of metastatic hormone-sensitive prostate cancer. Next slide, please. So this slide displays the stampede control arm. It tells us what happens when we use ADT alone. Here, the median failure-free survival was approximately 11 months. That means within 1 year, many of the patients have progressed towards castration resistance. Here, the overall survival was only 3.5 years. This is very important for us because for many years, only ADT monotherapy was considered the acceptable standard of care. But this data, it clearly demonstrates that ADT alone is inadequate for most of the missions. So there were subsequent trials which looked into intensification of the therapy. Next slide, please. Next slide. So historically, we always, as a patient developed the metastatic disease, prostate itself was often ignored. So the thinking was that the disease is already systemic, so local treatment, previous slide. Sandeep, can you go to the previous slide? Previous to this. Yeah, thank you. So once the disease is systemic, local treatment. Sandeep, next slide, please. Yeah, can you stay at this? The Stampede study had evaluated whether adding prostatic radiotherapy to systemic therapy could improve outcomes in newly diagnosed metastatic hormone-sensitive prostate cancer. So first we'll be looking at the low volume disease where patients had less than 4 bone metastasis. If you see the top left graph, we can clearly see the separation of the curves very early and there was persistent separation of the curves. The hazard ratio here was approximately 0.56. That means there is a 44% reduction in the risk of a failure event. So radiotherapy, it significantly delayed the biochemical progression, it delayed the radiological progression and also development of filtration resistance. If we look at the top right graph, it represents the overall survival that is in patients with low volume disease. Again, we can see here a hazard ratio of approximately 0.54. There is a mean separation of the favoring radiotherapy. So carefully selected low volume metastatic patients, local prostate radiotherapy, it translated to a overall survival benefit. So if we look at the high volume disease where patients had more than or equal to 4 bone metastasis, we can see that although there is some modest improvement in the failure-free survival initially, the overall survival curves, they essentially overlap and the hazard ratio is also almost close to 1, meaning that there was no significant survival benefit from local prostate radiotherapy in patients with extensive metastatic disease. So based on this Stampede trial, prostate radiotherapy is now the standard of care for low volume de novo metastatic hormone sensitive prostate. This is especially for fit patients and for those patients with oligometastatic disease. Whereas in patients with extensive high volume disease, systemic intensification is a major priority. Next slide, please. So this slide, it summarizes the evolution of how the systemic intensification trials had happened. So we have moved from docetaxel to abiraterone, enzalutamide, apalutamide, and now we are moving to triplet therapy. So the most important thing to be noted here is that every successful strategy, it improved the survival when compared to ADT alone. For example, if we see the chartered, docetaxel improved the overall survival. In latitude, abiraterone improved overall survival. Titan trial, apalutamide improved the overall survival. Enzamet trial, enzalutamide improved the overall survival. Similarly, Arescens trial, triplet therapy, it improved the overall survival. So today, just ADT monotherapy is no longer acceptable for most of the fit metastatic patients. But the challenge here is how do we select these drugs, whether we give a ARPI doublet or whether we give a chemotherapy doublet or do we do a triplet therapy. Now the main task is deciding between which patient will get which sort of therapy. Next slide, please. So we will be, in the coming slides, we will be looking briefly into some of these trials. So first we will start with the charter trial. The charter trial was actually practice changing. Before charter, docetaxel, it was mainly reserved for the metastatic castration resistant disease. In chartered, patients were randomized to ADT alone or ADT plus 6 cycles of docetaxel. Here, patients were categorized into high volume and low volume disease. High volume disease was defined as with visceral metastasis or 4 or more bone mets with at least one beyond the axial skeleton. So in high volume disease, patients receiving docetaxel plus ADT, they had a median overall survival of almost 51.2 months when compared to only 34.4 months with ADT alone. So there is an improvement of approximately 16.8 months in the overall survival. And the hazard ratio here was 0.63 with a highly significant p-value. So this was one of the major demonstration that early treatment intensification, it dramatically changes the long-term outcome. Similarly, if we look at the low volume disease patients, here the median overall survival was almost 36.5 months with the combination of docetaxel with ADT, while ADT alone arm, it did not even reach the median overall survival. Hazard ratio in the low volume disease population was 1.04 and the p-value was also not significant, meaning that there is no clear survival benefit with upfront docetaxel in patients with low volume disease. So this is very important for us clinically because this trial has suggested that not all the metastatic hormone sensitive prostate cancer, they behave the same biologically. So low volume disease, it may remain highly hormone sensitive for prolonged periods of time. So usually these low volume disease patients, they might derive substantial benefit from androgen receptor pathway inhibitors, and they might not need more immediate chemotherapy. Whereas the high volume disease patients, the disease behaves much more aggressively and they benefit from early starting of chemotherapy. Next slide, please. So here, let's have a look at the Latitude trial. Latitude trial, it evaluated the addition of abiraterone plus prednisolone to the standard androgen deprivation therapy. This is in patients with newly diagnosed high-risk metastatic hormone-sensitive prostate cancer. So if we look at the Kaplan-Meier curve on the left side of the slide, we can clearly see that there is a very early and sustained separation of the two curves. Here, the median overall survival, it improved dramatically, approximately 53 months with abiraterone when compared with 36 months with the androgen deprivation therapy alone. The hazard ratio was 0.66, corresponding to an approximately 34% reduction in the risk of death. And p-value was also highly significant here. Now, if we look at the table on the right side, we can also see major improvements across multiple clinically meaningful secondary endpoints. Abiraterone, it also delayed the pain progression, it delayed the skeletal related events, delayed initiation of chemotherapy, and also progression to castration resistance. Here, one particularly important point which was highlighted here is the prostate-specific antigen progression. Here, the hazard ratio was extremely favorable, showing profound disease suppression. However, we must also carefully interpret the control arm also. In the Latitude trial, many of the patients in the control arm, they had a delayed access to subsequent therapies, and there was also delayed treatment intensification after the CRPC development. So, although Latitude established abiraterone as a very effective upfront option, part of this benefit may also reflect the undertreatment of the control arm. Next slide, please. So we have seen how patients in the Latitude benefited with abiraterone, but always efficacy must be balanced against the long-term tolerability. So as we all know, abiraterone is very effective, but it is not toxicity free. The most important toxicities with abiraterone are hypertension, hypokalemia, hepatotoxicity, fluid retention, impaired blood sugar control, and so many other metabolic complications. So this is very important because most of the metastatic hormone sensitive prostate cancers, they stay on therapy for years. So chronic toxicity, it matters a lot in the hormone sensitive prostate cancer patients when compared to the CRPC patients. So especially in elderly, diabetic or cardiac patients, these considerations are even more relevant when we are selecting any of the therapies. Next slide, please. So next coming up is the Titan trial. So in the Titan trial, patients with metastatic hormone-sensitive prostate cancer, they were randomized to receive apalutamide along with ADT versus placebo plus ADT. So this trial had included both high volume and low volume disease patients, and it also included both de novo and recurrent metastatic presentations. So as we can see, the hazard ratio for progression-free survival was 0.48. That equals to approximately 52% reduction in the risk of progression or death. P-value again is significant here. This demonstrates that there is a very powerful disease control with apalutamide. We can also see that the hazard ratio for overall survival is almost 0.65, which approximates a 35% reduction in the risk of death with addition of apalutamide to ADT. This confirmed that the potent androgen receptor inhibitors, initiating them early in the disease course, it produces a durable survival benefit. If we look at subgroup analysis, especially with regards to the low volume and the high volume disease, we can see that the hazard ratio in the low volume subgroup was 0.36 And the benefit was also maintained in the high volume disease with a hazard ratio of 0.53. So the Titan trial, it suggested that potent androgen receptor pathway inhibition, it will be broadly beneficial regardless of the metastatic volume. Next slide, please. So next comes the Enzamet trial, in which enzalutamide was evaluated along with the androgen deprivation therapy. Here in the Enzamet trial, patients with again metastatic hormone sensitive ADT plus enzalutamide or a conventional non-steroidal anti-androgen like the bicalutamide, nilutamide or the flutamide. So we can see that the hazard ratio for progression-free survival was 0.40 and the hazard ratio for overall survival was 0.67. Similarly, for low volume disease, the hazard ratio for overall survival was 0.43. This is an extremely impressive benefit. In contrast, we can see that for high volume disease, the hazard ratio was 0.8. So with enzalutamide, the magnitude of benefit, it appeared particularly striking in the low volume disease patients. So this comes us to one important clinical pattern that for low volume disease, the androgen receptor pathway inhibitor based strategies, they may provide substantial long-term benefit without exposing the patients to chemotherapy toxicity. Whereas in the high volume disease patients where the disease is aggressive, most of us still favor chemotherapy containing approaches only. Next slide, please. So what can we do? Can we intensify the therapy more? Led to the development of the PEACE-1 and the Arasens trial. Next slide, please. So let's look at the PEACE study design. The PEACE trial, it included de novo metastatic hormone-sensitive prostate cancer patients, and patients with recurrent metastatic disease were excluded, and also patients who received prior chemotherapy were excluded in this trial. And the patient could have either high volume or low volume disease. PEACE-1, this is a very important study, but it is somewhat a complex study because the study had evolved over time. The study was started approximately in 2013. It evolved, means the treatment arms have changed over time because the standard of care also changed during the trial conduct. So initially the standard of care was ADT alone. Later the standard of care became ADT plus docetaxel. So this trial, it essentially evaluated whether adding abiraterone, it further improved outcomes. This was not originally designed specifically as a pure triplet versus doublet study, but ultimately it gives us very valuable evidence supporting triplet intensification, especially in patients with high volume disease. Next slide, please. So if you look at the actual efficacy results from this PEACE-1 trial, particularly focusing on the addition of abiraterone to ADT plus docetaxel, we can see that in patients with high volume disease, adding abiraterone to ADT plus docetaxel, it significantly improved the outcomes. We already knew that docetaxel improves survival in high volume disease. We have already discussed about this. So now PEACE-1, it showed that even after giving docetaxel, if we add additional abiraterone, it still provides incremental benefit. However, in low volume disease, it did not demonstrate an equally dramatic benefit. Next slide, please. Now let's look at the Arasens study design. Arasens, it was specifically designed to answer a very focused clinical question that can we improve the outcomes beyond ADT plus docetaxel by the addition of darolutamide. Here the patients were randomized 1:1 into two groups. One of the arms received darolutamide plus ADT plus docetaxel. The control arm received placebo plus ADT plus docetaxel. This trial, it enrolled metastatic hormone sensitive cancer patients with good performance status of 0 to 1, and patients who were considered as suitable candidates for both ADT and docetaxel were only enrolled in this trial. Here, the patients are stratified based on the extent of the disease, including M1A, M1B, and M1C disease. Patients were also stratified based on the alkaline phosphatase levels. So the primary endpoint of this trial was overall survival, and there were multiple clinically meaningful secondary endpoints also, which are included in the trial. The secondary endpoints included the time to CRPC, the time to pain progression, skeletal related event outcomes, time to subsequent therapy, opioid requirement, and symptom worsening. One of the major strengths of the ARISEN study is the excellent docetaxel delivery. Next slide. Nearly almost 90% of the patients, they completed all 6 cycles of docetaxel. And also toxicity profiles between the arms, even after treatment intensification, that is after addition of darolutamide also, the toxicity was not much different between the 2 arms. Next slide, please. If we look at the overall survival for the overall population, we can see that the median overall survival in the darolutamide arm was not even reached at the time of this analysis, whereas in the placebo, median survival was approximately 49 months. Hazard ratio for overall survival was 0.68, corresponding to a 32% reduction in the risk of death with addition of darolutamide, and the p-value being significant. Next slide. If we look at the upper right graph, it shows the overall survival in the high risk patients. Here we can see a clear separation of the curves. Hazard ratio was 0.71. The lower right side of the graph, it represents the lower risk subgroup. We can see that the lower risk subgroup also demonstrated with the addition of darolutamide, where the hazard ratio was 0.62. So this trial, it firmly established that triplet therapy is a new standard for fit patients with de novo metastatic disease, particularly for high volume disease. Next slide, please. So this slide shows 4 key efficacy endpoints. The upper left graph, it shows the time to castration-resistant prostate cancer. Here, darolutamide triplet therapy, it achieved a 64% reduction in the risk of progression to CRPC. Hazard ratio of 0.36 and the p-value is significant. If we look at the upper right graph, it shows the time to first subsequent anti-neoplastic therapy. We see here that there is a 61% reduction in the risk of requiring subsequent therapy. Hazard ratio of 0.39. Bottom left graph, it shows the time to pain progression. So the triplet therapy reduced the risk of pain progression approximately by 21%. Lower right graph, it shows the time to first symptomatic skeletal event. Although here the curves separate more modestly, there is still some clear benefit favoring darolutamide therapy. So when we put all these into together, all these endpoints together, ARISEN shows us that triplet therapy is not just about extension of survival. It also is clinically meaningful for the patient. It delays the development of resistant disease. It delays progression. It delays pain. It delays skeletal morbidity, and also it delays the need for future therapy. Next slide, please. So we know that the depth of the PSA response, it increasingly correlates with the long-term outcomes. So the bar graph, which we can see here, it shows the percentage of the patients achieving undetectable PSA at different time points. They have checked it at 24 weeks, 36 weeks, 52 weeks, and at any time during therapy. And the difference here is very striking, that we can see that at 24 weeks, approximately 49% of the patients receiving darolutamide triplet therapy, they achieved undetectable PSA compared to only 24% in the control arm. At 36 weeks, it was 57% versus 25%. At 52 weeks, it was 60% versus 26%. Overall, we can see that more than 2/3 of the patients receiving triplet therapy, they achieved undetectable PSA at some point of time. Next slide. So the lower left graph, which we can see, we see here the time to PSA progression. Patients achieving an undetectable PSA, they had a dramatically prolonged disease control. Next slide, please. So here the graph on the right, it shows us overall survival according to the PSA response status. So here the patients who achieved undetectable PSA at 36 weeks, they had dramatically superior survival compared with patients who did not achieve this undetectable PSA levels. The reduction in the death was approximately 63% here. And also achieving PSA below 0.2, it strongly correlated with improved survival. Next slide, please. So this slide depicts the status of the high volume disease and the correlation with the PSA outcomes. Similar to the previous slide, we can see that here the upper left graph, it shows the rates of undetectable PSA over time. Again, we can see here that there is a very striking difference which is favoring darolutamide triplet therapy. We can see that at 12 weeks, 24 weeks, 36 weeks, and 52 weeks, the percentage of patients who achieved undetectable PSA was much higher with the triplet therapy. Next slide, please. The lower left graph here, it shows the time to PSA progression. Again, the separation of the curves here is very dramatic. Patients achieving undetectable PSA had prolonged periods without PSA progression, with median time not even reached in many of the patients. Next slide, please. The right side part of the graph, it shows the overall survival. Again, we can see that there is a very clear and sustained separation between the two curves. Hazard ratio of 0.3, which is highly favorable. It shows a substantial reduction in the risk of death with darolutamide triplet therapy in patients with high volume disease. Next slide, please. Similarly, if we look at the same parameters in patients with low volume disease, so we can see here that even with even patients with low volume disease, they achieved excellent PSA suppression. More than 80% they achieved undetectable PSA levels. Next slide, please. The graph here, lower left side, it shows the time to PSA progression. We can see that there is a very clear separation between the two curves. Next slide. The overall survival graph displayed on the right side. Here we can see that the survival outcomes in the low volume disease, they're already quite favorable for overall. And yet for patients who achieve undetectable PSA, they still appear to maintain this prolonged survival. However, the question still remains that do all low volume patients, they require triplet therapy, or can these some of the low volume patients may be adequately managed with just ADT and androgen receptor inhibitors? Next slide, please. So clinically, how would we decide between a doublet versus a triplet? So how do we choose? Basically, it's basically we look into the disease burden, whether it is a high volume disease, whether there are visceral metastasis, and how rapid the PSA is rising. The therapy also depends upon the patient's fitness, whether the performance status of the patient, the bone marrow reserve of the patient, and any pre-existing conditions like neuropathy. Therapy is also decided based on the aggressiveness of the disease, whether it is a de novo disease or there is a short PSA doubling time, and how is the symptomatic burden. And obviously, the next comes the financial issues, the access to therapy. So generally for low volume disease, it is usually ADT plus androgen receptor pathway inhibitor. But for high volume fit patients, triplet therapy is a strong consideration. because once resistance develops after the androgen receptor pathway inhibitors, docetaxel may become less effective. Next slide, please. So with that, I conclude my presentation. Thank you all for patient hearing.
Thank you, Dr. Shiny. That's a very nice presentation. You have clearly explained all the clinical studies, starting from latitude and stampede, the latest studies. And for the next talk will be Dr. Rajni Priya. She is consultant from Mahatma Gandhi Cancer Hospital, Visakhapatnam. Over to Dr. Rajni.
Meher ma'am, is my screen visible?
Yes,
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 ma'am.
Okay, ma'am. Thank you, Bear, and thank you, Meher Lakshmi ma'am, for giving me this opportunity. So today I'll be for the next 15 minutes, I'll be talking on advancing metastatic hormone-sensitive prostate cancer treatment horizons, darolutamide without chemotherapy. We have the evidence of Aeronaut trial. So this has been extensively discussed by Dr. Shiny ma'am. So how we have moved from just starting with ADT to addition of docetaxel, then came the hormonal strategies like your abiraterone and the newer anti-androgens like the enzalutamide, epalutamide, and darolutamide now. From the doublet combinations, now we have moved to further intensification of the treatment based on whether the patient is a high volume or low volume or a high volume disease, or high risk or the low risk disease based on charted or latitude criteria which we use. So based on that, now we are deciding on whether to go with the doublet therapies or the triplet therapies, taking it into account many factors apart from just the risk of the disease. We take into account the patient's age, comorbidities, whether the patient is on polypharmacy, to look for the drug-drug interaction. So there are multiple factors which we take into account while planning our treatment. Previously, the median survival of prostate cancer was, when I'm doing my DM, was only just 18 months to 24 months. But now we are talking of more than 5 years. And even in low volume disease patients, we have patients who live for more than 8 to 10 years as well. So this is how we are advancing in management of these prostate cancer patients. Next slide. So, but still, there are certain subset of patients where we can either intensify, that is, escalate a treatment or de-escalate treatment, and choosing the right anti-androgen or the hormonal therapy is very important. An unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for treatment of these metastatic hormone-sensitive patients without adding significant toxicities and with a low drug-drug interaction potentials. So, especially prostate cancer is disease of elderly. So, we don't want to subject the patient to various toxicities, especially with the chemo agents like a docetaxel. We have to choose even in the hormonal therapy agents, that is abiraterone or the newer anti-androgens. It is very important as an oncologist to choose the best combination, especially the hormonal agent in our patients. So, essence, previously we had this is a data which we have in the triplet therapy, that is ADT with docetaxel with darolutamide. It has clearly shown to have benefit in both high risk and low risk, though the majority of the patients who benefited with the triplet is high risk. Even in low risk patient, it has shown to have benefit. But if you see the confidence interval, it has crossed 1. So really, we do not know. And most of that as a post hoc analysis, we really do not know like how much the triplet therapy benefits in the low risk patients. And still now, many of our oncologists are comfortable in giving the triplet therapies only for patients who are fit enough to tolerate docetaxel and have high volume diseases. Even for low volume or low risk patients, we are still going with the doublet regimens. So till now, we are skeptical of what adding this darolutamide to ADT, because we don't have data in replacing our abiraterone or enza or apalutamide with your darolutamide. But now that we have darolutamide also being tried as doublet, and the data comes from the phase 3 study, that is a ARONET trial. So with the ARONET data, darolutamide has the potential to change the treatment paradigm, as now it would be the only androgen receptor inhibitor which could be used with or without chemotherapy. So darolutamide plus ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancers, especially for high-risk patients. In essence, darolutamide has shown to have a favorable efficacy and safety compared to ADT plus docetaxel alone. ARONET was designed to evaluate the darolutamide plus ADT versus ADT to provide a new treatment option for this hormone-sensitive prostate cancer patients without docetaxel. So this is a study design of the ARONET trial. It is a randomized, double-blind, placebo-controlled phase 3 study. Almost 665 patients were enrolled in the trial. So histologically or cytologically confirmed prostate cancers with patients with good performance status of 0 to 2, and the patients were stratified based on the visceral metastasis and whether the patient received prior local therapy or not. The patients were randomized in a 2:1 fashion to either darolutamide plus ADT. Darolutamide is given at a dose of 600 mg BD versus ADT alone. The primary endpoint of the analysis is radiographic progression-free survival. The secondary endpoints are the overall survival, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to
Rashmi,
PSA.
sorry to interrupt
Rashmi,
you.
your
Why are your
slides are
slides
not
not
moving.
moving?
It's not moving, ma'am.
Yeah, the
I
slides are not
noticed just
moving. You're
now.
spinning
Yeah,
the slide.
I
You're
thought it's
spinning the
you're just
title
giving
slide.
introduction.
Yeah, even
No,
I thought
I'm
you were
moving the
telling
slides.
introduction. No, your slides are not moving. Actually, you have to
Now they're
enlarge
moving.
the Rajni.
No,
No,
the
you
slides are
start
not moving.
slideshow. Rajni,
Uh,
you start slideshow. You didn't start the slideshow.
I started, ma'am, actually.
It
Something
is
is
not
wrong.
displaying like slideshow. Like when you
No,
start the slideshow, the rest of the slides are not visible, right?
yeah. No, I had started, ma'am.
But the
Still
slides
they're
are
not
not
moving.
moving.
No,
You are
log
in the
out and log in
introduction
again.
slide only.
Stop sharing and start sharing again.
Stop. Share. Moving, ma'am?
Yes, now they are moving. Yeah, now they are
Oh,
moving.
now,
Okay. So this we have already discussed. So this is a study design of the ARONET study. So the primary endpoints are radiographic progression-free survival. Secondary endpoints are the OS, time to initiation of subsequent therapy, time to CRPC, time to PSA progression, and rates of undetectable PSA, that is less than 0.2 nanogram per ml, and time to pain progression and safety. So other pre-specified endpoints are PFS2, time to skeletal-related events, time to deterioration of the FACT-P total, and time to first prostate cancer-related invasive procedure. So initially, the patients are double-blinded until the primary analysis. And after the primary analysis, they were then taken up to the final analysis, and 100% crossover to darolutamide was done. And then selected endpoints like OS and safety were also analyzed. Coming to the baseline characteristics, if you can see between the both arms, darolutamide plus ADT versus ADT alone, all the patients were all the characteristics were well balanced between both the groups. So coming to the Asian population in the study, almost 30% were the Asian population. And if you take whether it is a metachronous or a synchronous, you can see 70% of the patients were the synchronous or upfront metastatic disease, with metachronous being 22%. Coming to the high volume patients, 70% are high volume patients, and 29% were low volume patients. So this is what we routinely see in our practice. We see more number of high volume patients in our practice. So this is in line with our routine practice. Coming to the Aeronet trial, we have 30% of populations from the Asia, 29% from Latin America, and 41% for Europe and rest of the world. So from Asia, we have Indian representation of almost 13.7%. So coming to the primary endpoint, that is radiographic progression-free survival. So if you can see the Kaplan-Meier curves, so with the darolutamide addition to ADT, it is at a median follow-up of 24 months, it is 70.3%. Whereas with ADT, it is only 52%. So there is an absolute almost 18% improvement in radiographic progression-free survival with hazard ratios of 0.54, that is 46% relative reduction in the radiographic progression of death. Coming to the median, if you take the median radiographic progression-free survival is not reached. When compared to ADT alone, it is 25 months. Coming to the benefit of the darolutamide plus ADT on radiographic progression-free survival, if you see the subgroup analysis, so it is seen in almost all the subgroups, that is irrespective of the age, the PSA levels at presentation, the performance status, the Gleason score, whether it is high volume or low volume, based irrespective of the ethnicity, the geographic location, and presence or absence of visceral metastasis or prior local therapy. So almost all patients benefited with the addition of darolutamide to ADT. So even if you see even the high volume and the low risk patients, though low risk patients benefited most with the addition of this doublet, but the population of the patients of the low volume are less. Coming to the secondary endpoints, that is overall survival and other endpoints, they all are also significant in the darolutamide arm compared to the ADT arm alone. And at the time of primary analysis, OS data was immature. Since OS is immature, patients were followed for survival. All remaining per protocol placebo patients often cross over to darolutamide after the primary analysis. So coming to the time to CRPC progression, so if in the darolutamide arm, the median is not reached compared to 13.8 months in the placebo arm with the hazards of 0.4. Coming to the time to pain progression, in the darolutamide arm, it is not reached compared to 29.9 months in the placebo arm with the hazards of 0.72. So it clearly shows that darolutamide addition to ADT delays in time to progression. It can be of high importance to patient and have not been demonstrated with other AI inhibitors alone. Coming to the fall of PSA, so we had seen in our practice, darolutamide causes very rapid and very deep PSA fall. So for patients who have very deep PSA responses, they have shown to have an improved survivals. So at any time point, if you take darolutamide causes less PSA levels. So you can see it's almost 62% versus 18.5%. And the time to PSA progression is also prolonged with the addition of darolutamide compared to placebo with a hazard ratio of 0.3. Coming to the timelines and based on the volume of the diseases, so irrespective of the volume of the diseases and starting from 24 weeks, 36 weeks, 48 weeks, and at any time point, more patients in the darolutamide arm had undetectable PSA compared to placebo alone. Coming to the number of patients who had discontinued in the study, it is 45%, which is less compared to ADT alone. And coming to the subsequent life-prolonging systemic therapies, it is 32% in the darolutamide arm compared to 42%. And majority of the patients received chemotherapy as a subsequent therapies. Coming to the incidence of the treatment emergent adverse events, so we all know that darolutamide is a very safe hormonal therapy to use in our practice compared to abiraterone, which comes with so many side effects, and even enzalutamide, which especially in elderly, which were more concerned of the falls, the seizure, but seizure risks compared to apalutamide, it has less incidence of rash, hypertension, or derangement. Compared to abiraterone, obviously it is a very safe anti-androgen to use. coming to the side effects which we see with darolutamide, majority of the or some patients may complain of either arthralgias or myalgias. Rather than that, we don't have any grade 3-4 toxicities or toxicities which are to be mainly concerned of. So this is what we have discussed. So it's a very safe hormonal agent to be used. With fatigue rates also, if you can see, it is only 5%. And they are not very severe, like not grade 3 or grade 4 toxicities. So coming to the ASCO 2025, darolutamide extended median time to deterioration in the FACT-P total score by 5.1 months versus placebo. Darolutamide is the first and the only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being. So patients are very comfortable taking this darolutamide, especially with ADT, especially in patients with low burden or low risk patients, or even in patients with high risk where they cannot tolerate docetaxel. This is a very good combination to go with. Coming to the darolutamide doublet therapy, it also demonstrated clinically meaningful delay in deterioration of overall well-being, especially on the social, functional, urinary symptom domain. So finally, to conclude, darolutamide plus ADT significantly improved radiographic progression-free survival in patients with metastatic hormone-sensitive prostate cancer, and it showed benefit across all secondary endpoints. So darolutamide was associated with the deep PSA responses regardless of the baseline PSA, and is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social, functional, and urinary symptoms as well. And above all, it is a drug with a favorable safety profile. Thank you, ma'am. So this doublet is a new additional standard of care in treatment of these hormone-sensitive prostate cancer patients.
Thank you, Dr. Rashmi. Thank you for your clear presentation. Yes, darolutamide has definitely changed the treatment landscape. It has brought many changes. And let's discuss. I'll be presenting a short case followed by a few questions. Please stay for the question answer session. Sandeep, can you start sharing the screen from your side?
Ma'am, 1 minute, ma'am, sharing the slides. Ma'am, hope the slides are visible.
Yes, yes. Yes. You can put in a slideshow mode.
1 second, ma'am, doing it.
A very good evening, everybody. I will present a short case which we treated recently. This is a case of a 67-year-old man who underwent evaluation for obstruction in flow of urine and blood in urine. He had history of hypertension, diabetes, mellitus for 20 years, and investigations were suggestive of urinary tract infection with high serum PSA. And subsequently, PSMA PET CT and trust-guided biopsy were done. Next slide. His serum PSA was more than 153 nanograms per ml. Next slide. Subsequently, trust-guided biopsy was done. This is the PSMA PET CT. Next slide. Shall we go to next slide? So this is the impression on the, we showed PSMA expressing locally advanced prostate primary and PSMA expressing cervical, supraclavicular, mediastinal, abdominopelvic lymph nodes, mesorectal nodes, and skeletal lesions. So there is widespread metastasis. Next slide. Both visceral and skeletal mets. This is a trust-guided biopsy report. Next slide. This is shows, next slide again. SNR adenocarcinoma. Next slide. This is the HP report. Overall, let's see. Not able to see properly. So physiological, so Gleason's is 9 and histology is adenocarcinoma. Next slide. So this is the final grading. If you see 4 plus 5, 9 is the Gleason's. And yes, next slide. So now we have finally a patient with metastatic castrate-sensitive prostate cancer with high risk and high volume. You can see the extensive disease on the scan. Next slide. He was started triplet therapy with degarelix, docetaxel, and darolutamide. He was also started on antibiotics for UTA, and he improved symptomatically in a month. So PSA levels started falling. March was more than 153. April 0.92, July 0.2. So he improved near normalcy and has continued on therapy. He recently completed even 6 cycles also. These are he finished all therapies and then he's continuing on darolutamide as of now. Next slide. So this is the case. As you can see, there's a dramatic fall in the serum PSA with the start of the triplet therapy. So now we'll discuss a few questions. Yes, next slide. Next slide. So we have seen how the treatment paradigm of HSPC has changed in 2026 from ADT alone to doublets and triplets. Starting from 2015 to 2017, where we have found that the ADT alone becomes insufficient. We had multiple trials where Dr. Saini has beautifully described all the initial clinical trials, the Latitude, Stampede, and all the clinical trials. From 2018 to 19, and doublets role is expanded. ARPA doublets were established with other clinical trials like Enzymed, Archie's, Titan, etc. And 2022, we have the data from PEACE-1 and Erasmus, where PEACE-1 is the combination of Ibdartron, docetaxel plus ADT, and Erasmus with darolutamide, docetaxel plus ADT. 2024, we have the Arnaud data of darolutamide plus ADT alone, where Dr. Shaini has described all the studies of the study with the Arnaud and all the benefits with the combination. And 2025-26, we have the current standard. Doublet ARPA for most and triplet for fit, high volume, and de novo aggressive metastatic HSPC. So patient selection framework, if you see high volume, high risk, plus fit, triplet is preferred. Low volume and unfit for chemo, ARPA doublet. And where we can go biomarker driven strategies, but these are basically in the subsequent lines, not in the first line. I'm sorry. Next slide. So we have a few patients. Which patient phenotypes most clearly TP or towards ARPA doublet versus triplet intensification? Though we have seen, we'd like to quickly hear from you in your real world practice. Dr. Shaini?
Ma'am, for doublet usually for low volume disease, madam. Low volume disease, elderly or patients who have comorbid conditions or patients who are not fit, who already have some cardiac comorbidities or poor performance status, for them doublet mostly. And high volume disease, especially visceral metastasis, high symptomatic burden, patients who are fit to receive chemotherapy. So these are the people whom I look towards triplet, addition of docetaxel also.
Yes, agree with you. And anything else you want to add, Dr. Rashmi?
No, ma'am. So I agree with ma'am. So it's mainly the high volume or the low volume disease and the patient fitness and the comorbidities which we
Most
take into account.
important, yes. Most important factor which I feel is the performance status, and obviously the bulk of the disease, as I said, volume matters.
Visceral mets, yes,
Yes.
visceral mets, where we have to go with the triplet because they're very aggressive and they do badly. So we have to be very aggressive from the very first.
Yes, we had few patients, they had a very high disease burden, and these patients are also very sick. So we
Yes,
feel
ma'am.
that they might not be fit for triplet, but most of them they tolerate it. As we have seen in a clinical practice, tolerance is good even with triplet therapy. Though initially we had that fear of whether they'll be able to tolerate the triplet or not. But as the practice has evolved, we have seen that patients are able to tolerate triplet therapy quite well, even if they're elderly age. Next slide.
We are giving 50 mg per meter square, ma'am, per 2 weekly. If the
2
patients
weekly.
are like, if you feel that we cannot tolerate, yes, yes.
Yes. Actually, in our institute, 50 mg is quite less. I gave only for 1 or 2 patients. They're tolerating the full dose actually, every 3 weekly.
Okay.
Next, when abiraterone or enzalutamide combinations feel suboptimal, what are the most common clinical or practical triggers for other combinations? I think they have answered in the paragraph only. Dr. Rajni, what is your first
Yes, ma'am.
choice?
So previously, I have good experience with abiraterone, ma'am. The main issue is with the cost. So abiraterone is a cheaper one compared to other androgens, anti-androgens. So I have more experience with abiraterone, though we know that abiraterone comes with the more toxicities compared with enza, epa, or darolutamide. So if there are no financial constraints, the best one to go is the darolutamide because it does not need steroids. It doesn't have any cardiovascular risk or any CNS toxicities like a falls or seizures and less drug-drug interactions. So it's a very safe drug to use. So if there are no cost concerns, definitely our choice will be darolutamide. Previously, we were skeptical to use in the as a doublet because we did not have any data. But now that we have data from the Aronet trial as a doublet also, so we are more convinced to use darolutamide in our patients.
Dr. Shiny, we would like to hear from you. You are working in a corporate hospital, Omega Hospital, clientele is quite different. So what are practical triggers to use and how do you choose therapy? Anyway, we undoubtedly are sure that darolutamide is definitely superior. Are there any other specific factors you look at when you're practicing in
Yeah, for
your setup?
abiraterone, as already Dr. Rashni has discussed during my PG days and post that also, we all have good experience with abiraterone, but especially most of the prostate cancer patients are elderly and many of them have diabetes. So giving prednisolone, blood sugar control is a huge problem with them. And metabolic abnormalities with abiraterone is a big problem. So, and the other drug, if we look at enzalutamide, it also has some cognitive issues, the risk of falls, the risk of seizures, and more concerned about drug interaction also because these are oral medications and patients will be using multiple other medications, especially for diabetes if they're using metformin and all. Then because enzalutamide is a cytochrome P inhibitor, so it can the levels can increase and the patients can have more toxicity when they're using enzalutamide along with other medications. So that is one concern with enzalutamide. Having said that, nowadays, as Rajni has clearly told, the cost is always a concern. So I use the drugs depending on this one. Enzalutamide, I put for like middle range people. I'm using enzalutamide, not that I'm not using. Luckily, I didn't have any patients who have had falls and any seizures. I'm just alerting them that if they have any of the issues, that they should report back. I'm actually starting with a little overdose of enzalutamide and just reviewing after a month and then increasing the dose gradually because of this risk thing. Daro, I didn't use in any of the patient as of now. So I'm because of the less side effects, I'm really looking forward. And since we have data that even doublet has good results, I am looking forward to use darolutamide.
Thank you. Next slide. Which Arano strengths most impact adoption versus currently approved doctors? Frequent elders. I think this was already discussed. Next slide. How do the volume data clarify the appropriate patient for triplet? All- Next slide. Next slide, Sandeep. Development doublet versus alternate regimens. Next slide. There's one important thing I want to discuss. Drug-drug interactions are also discussed. Next slide. This I feel is the most important part of this questionnaire. Dr. Rajni, can you take this first? In the era of Arnaud, Arasens, Alzheimer's, Peace, and Titan, how should Indian oncologists approach treatment sequencing to preserve options at metastatic CRPC stage? What do you think are the best sequence options? See, in CSPC, we are very clear. The patient is fit and he had high volume and all this. We go for triplet therapy or else doublet therapy. All that is fine. What about CRPC? Now we have so many options, human chemotherapy options. We have ARPS, and we have this what do you call biomarker driven therapy. Suppose he has some mutation in HRR gene panel, we try to target them. So, and apart from all these, we have other therapies like lutetium also. So how do you place all this, Dr. Rajni?
Yes, ma'am. So definitely, as we've already discussed from the very start of the session, for high volume patients, we always go for triplet therapies. We are almost left with very little options in the CRPC state. So if the patient had we have already received docetaxel and also your hormonal therapies. Then obviously in the later therapies, we have only cabazitaxel, we have lutetium therapies. And as you told, this is the time where we do a HRR panel. We look for any target. So we have the PARP inhibitors also in a basket. So based on that HRR panel, and also if it's negative, then we go for lutetium therapy or cabazitaxel. So that's how we go in CRPC state, ma'am. So but if the patient had received only doublet like your ADT with your hormonal agents, maybe then we can go with the docetaxel in the CRPC state. And in later stages, we can go for other options like your lutetium or PARP inhibitors or cabazitaxel and so on and so forth. So the what we have learned in any other malignancy, the best.
Thank you, Dr. Rajni. And Dr.
Yes, yes, ma'am. Hello?
Madam,
Yes,
hit
yes, you
hard
can
and
continue,
hit
Dr.
early.
Rajni.
No, ma'am. I am done. Hello?
Dr. Shaini, your thoughts
Yes,
on the
madam, hit
options
hard
and
and
how do
hit
you sequence?
early. So as with other
So you're hitting
diseases,
hard first.
hitting hard and hit early, especially for high volume people. Low volume, doublet. On progression, only then only these HRR mutations and all they play a role, not as a first line. If they are progressing on these initial standard of therapy, then if HRR mutation is there, then I would look for PARP inhibitors. Our center, yes, we are doing lutetium therapy quite for many of our patients. Actually, I was asking for some strontium therapy before pain relief and all, but I know it carries a lot of bone marrow suppression. So that is the thing, madam. We are using lutetium therapies also in most of our patients when we exhaust all these androgen receptor pathway inhibitors, docetaxel, cabazitaxel. Then we are going for the lutetium therapies.
And have you done HRR panels on any of your patients? And
I have done, but I didn't see any mutation as of now, madam. Like whomever I'm treating.
even in all those patients, even those patients whom I have seen, I didn't see any targeted mutations as of. So next slide. Next slide. So this is the 2026 treatment message. ADT backbone is always essential. Androgen deprivation remains foundational therapy for all metastatic HSPC treatment strategies, providing essential testosterone suppression. ADT alone is obsolete. And ARPA doublets are standard. ARPA plus ADT combinations represent current standard of care for majority of metastatic HSPC patients. 3 approved ARPAs provide treatment flexibility, allowing selection based on patient-specific factors. And triplets for aggressive disease. Triplet combination offers greater survival benefit, particularly for fit patients with de novo high volume disease. Patient fitness assessment is crucial for triplet consideration, including performance status evaluation. Next slide. Thank you, Dr. Rajni, and thank you, Dr. Shaini, for your excellent talk and excellent inputs. And I thank Bayer for this today's meeting. Over to Sami.
Thank you, ma'am.
Thank you so much, ma'am. Before we close, ma'am, let me check the chat box if any questions are there. So if not, we can conclude the session. Ma'am, I don't see any questions in the chat box. So with this, my sincere thanks to Dr. Mahalakshmi ma'am and Dr. Shaini Reddy ma'am and Dr. Rajni Priya ma'am. And thanks for patient listening as well as for the audience. And my sincere apologies for the technical glitch in the beginning. So with this, we can conclude the session. Thank you so much, ma'am. So
That's fine, Sandeep.
Thank you.
Thank you.
thank you, ma'am. Thank you.
Thank you.
Yeah. Technical team, we can conclude the session. Please close it.
Okay, we are closing the session.